Our first speaker today is Dr. Pengyue Zhang. Pengyue is an assistant professor of biostatistics and health data sciences here at Indiana University.
Thank you for the introduction. So I'm going to introduce a few methods and examples for identifying precise drug response from real-world data. So in the first work, this is a methodological work trying to identify adverse drug-drug interactions in patient subpopulations. We identified adverse drug event cases as well as controls. First, we wanted to identify the optimal comparison method for each adverse drug event case, because if we want to identify adverse drug events, we can compare drug exposure between the cases and the controls, or we can compare the drug exposure immediately before the case and in a long time prior to the case. Well, the within individual-based comparison, comparing the drug exposure immediately within the case and in a long time prior to the case, can control unobserved confounding effect within the same individual. This method may not be powerful to identify drugs that require a long time to demonstrate the adverse effect. So we use the patient characters and drug labels to develop a supervised machine learning model, try to identify the optimal control selection methods for each adverse drug event case. And we've shown that the AUC can be improved by 10% under this optimal control selection. Then we developed a trajectory-informed model. We assume the drug combinations belongs to 3 different classes. Most of the drug combinations are safe. Some of the drug combinations are toxic. Well, there are another group of drug combinations. They are safe in the general population, but the risk could be increased as the number of the risk factor increases. Then we apply this trajectory-informed model to the optimum data. We identified 60% of the drug combinations remained safe in all the populations, and 4% of the drug combinations always had an increased risk. Well, 37% of the drug combinations, they were safe in the general population, but they had a higher risk in certain subpopulations. For example, some drug combinations may only have a higher risk in patients with female gender and older age, but remain safe in the general population. Second, in the second work, this is a data mining work. We would like to explore the relationship between drug dose and the risk of adverse drug events. We identified adverse drug events from the optimum data, and then we identified potential risky 3 drug combinations. For example, concurrent use of an antihypertensive drug and an opioid and antidepressant drug may increase the risk of dizziness, because all of the 3 drugs may increase the risk of dizziness. Then we explored the comparative risk between the highest level of all 3 drugs to the lower level, to the reduced dose level, in which one drug had a lower level, while the other 2 drugs still had the highest level. We do identify the possible low-risk strengths for the high-risk strands. And this information can be used by clinicians to mitigate the risk of adverse drug events by lowering the dose of one drug without a significant compromise in the patient care. Third, we also conduct adverse drug event data mining with respect to the precise outcome. Literature showing mixed relationship between the SGLT2 inhibitor, which is a very common anti-diabetic drug. Literature show mixed relationship between the SGLT2 inhibitors and urinary tract infection. So we derived a very large cohort. We compared 128,000 SGLT2 inhibitor users to 141,000 GLP-1 receptor agonist users. And then we measure the exact risk with respect to Candida urinary tract infection and the non-Candida urinary tract infection, or the bacteria urinary tract infection. And we observe that the SGLT2 inhibitor is associated with increased risk of non-Candida urinary tract infection, but not associated with the Candida urinary tract infection. And we also explore precise drug response in Alzheimer's disease in patient subpopulations. So in this work, we compare the risk of Alzheimer's disease between metformin users and sulfonylurea users. So literature showing mixed relationships showing mixed comparative risk in Alzheimer's disease between metformin and sulfonylurea. Some studies show no association. Some studies showing there are associations in younger individuals. So we use a recently developed phenol age model try to estimate the biological age of the individuals based on non-blood-based biomarkers. Then we conduct the biological age-specific subgroup analysis as well as the age-specific subgroup analysis. We have observed that metformin compared to sulfonylurea is associated with a lower risk of Alzheimer's disease only in individuals who are biologically younger, but not younger with respect to the regular age. We suspect metformin may have some anti-aging effect, which may indirectly benefit in the protection of Alzheimer's disease. But the anti-aging effect only works in an early intervention fashion for those individuals with a younger biological age. Okay, thank you. That's all my talk.